Morning, everyone. Sorry for the delay. So today we have a special session again on radiology, and a lot of you had demanded that we would like to know more about the MR anatomy of the pelvis, especially in relation to carcinoma rectum. So my young faculty colleague, Dr. Sanyukta Gupta, who's an assistant professor in radiology, she will be talking to us about imaging of carcinoma rectum. Sanyukta, please.
Good morning, everyone. Thank you, Dr. Kapoor sir, Dr. Anand sir, for inviting me for this lecture. Today, we'll be talking about the MR anatomy of pelvis. This would be covered in under this, if we explicitly detailed anatomy of the carcinoma rectum will explain itself the MRI anatomy of the pelvis. So let's start this lecture. I'll be talking about the MR protocol, the specific sequences and the very important sequences which we have to take in the MRI imaging of the CA rectum, the relevant anatomy, how to stage rectal CA on MRI, the management, and we'll do a case-based learning also. So MRI, how is it important and why is it different from the CT? So CT doesn't actually delineates the anatomy of the rectum so nicely as MR, and we can further guide our multidisciplinary. We can further guide how to approach the MRI, how to approach this particular tumor, the management also. So the unresectable things we can clearly see on MRI, the involvement of the pelvic side wall or organ involvement. This makes the tumor unresectable. For the new adjuvant theory, if we have a T3 stage or greater with positive nodes and threatened CRM, we'll be talking about all this in detail. And primary resectable, just the tumor comes and its resectability is there, the T1 or the T2 stage. So in short, the MRI protocol. So very important is the T2 images we take. T2 is easily identified with the fluid in the bladder or in the spinal canal. T2 images. So for the MRI rectum or for any tumor in the cervix or any rectum, we need, very important are the orthogonal images to the tumor, orthogonal and long axis images along the tumor. How important are these? For first of all, we acquire these T2 sagittal images, and this, as we can see, this is the tumor. And if we take sections perpendicular to the tumor, we are clearly delineating the anatomy of the tumor irrespective to the wall, which upstages the tumor to T3. Similarly, we take oblique coronal images along the axis of the tumor. So these all sections have to be told to the technologist. So in the referral sheet also, we would need some detailed and clinical details, such as where the tumor lies on colonoscopy, on DRE, and what is the histopathology? Is it the anal canal involvement? Is it the rectum? If it's all available, we would always need that, and this would help us to plan our MRI. Another important sequence would be diffusion. Diffusion, that's B value greater than 800. That's a higher B value. And this, if it's a restricted diffusion in showing tumor, showing a restricted diffusion, then it's a kind of gives us high confidence to report this as tumor. Preferably, we use a 3 Tesla as a high resolution is there. And this is a phase direct coil we use specifically for it. So what all preparation is needed for if you send a patient for MRI rectum? Does it need an endorectal coil? No. Does it need an enema preparation? No. No IV contrast? No. So we don't need any serum creatinine value to report an MRI rectum. So you can just simply send the patient without any, just an antiperistaltic may help. So we can give an IM or IV injection as per, but this is also in our institute, we found that if we take a high resolution small FOV T2 images, that's more than sufficient to report. So we all know about the oncology surgery principles. You have to achieve R0, remove all tumor, R0 resection, And the other aim is to preserve the sphincter as far as possible. So we have to know the anatomy of the sphincter as well as to the tumor extent. So TME is the mainstay or the fundamental thing we do in CA rectum. So we remove all the mesorectal fat surrounding the rectum along with this bordered mesorectal fascia. So the important surgeries, if it's an upper or mid-rectal tumor, we usually do the low anterior resection. Here in this illustration, this is the tumor, and this is the area of the tumor, area of the excision. So this spares the lower anal canal, and thus is a sphincter saving surgery. Abdominoperineal resection, if it's include a lower anal canal tumor, and the tumor is here in this area, and the APR consists of removal of the external sphincter. Thus, patient will go for a permanent colostomy. We can do an intersphincteric resection. This another approach needs to be clearly delineated and specified on MRI, as it helps preserving the external sphincter, which is a voluntary muscle. So MRI basically is very helpful if we know the localization, and T1 or T2 staging basically can be more can be differentiated more on endorectal ultrasound, but for upstaging it to T3, we definitely need a MRI. So locally advanced, when we call it, it's a T3 greater than T3C, MRF positive, nodes positive, and EMVI. EMVI stands for extramural venous invasion. So all these conditions can be easily delineated. And if this happens, the tumor happens to be a locally advanced, the management changes, and it automatically goes to a neoadjuvant stage. Then we again do MRI for the restaging of the tumor. If there is a downstaging, we go for a surgery, depending on the organ of involvement. If it's in the same response, then or it's a clinically less response, then we go to a surveillance by an endoscopy on the CEA and a further MRI and short-term follow. Or otherwise, if it's another course of neoadjuvant is required, then we go for another chemoradiation. So depending on the locally advanced, we go for this. And for localized tumors for T1 and T2, we directly primarily go for surgery. So what is rectum? So this is a T2 sagittal image, and rectum is the distal most of 15 centimeter part of the GI tract. And for us radiologists, and we do imaging, we define rectum and we classify or we divide it into three parts: the low, mid, and the high. So the low rectum includes the anal canal, and it's the 0 to 5 centimeter, the lowermost, from the anal verge to the lowermost margin of the tumor. If it lies within 5 centimeter of the anal verge, it is a low rectal tumor. For mid, it's 5 to 10, and for high, it is 10 to 15. So what is a so the rectum lies between anal verge and the sigmoid colon. So sigmoid takeoff can be easily seen on the MRI. The mesorectum finishes over here, and the sigmoid mesocolon takes over the sigmoid. And sigmoid mesocolon is completely surrounded by perivascular vessels, and peritoneal reflection can be seen here, which we'll be seeing in the further slides. So you have to define, if it's a sigmoid colon, then again the management changes. If it's a rectosigmoid junction, then you have to specify the rectosigmoid function. And this is the below this will come as the CA rectum. So just the basic anatomy of the rectal wall and how it looks on the MRI. So the hypointense, so the rectum has three layers: the mucosa, the submucosa, and the hypointense muscularis propria. Hypointense is the black structure, which is very nicely delineated on T2 images, because T2 has the inherent fat, so it acts as a contrast, and we can easily delineate the margins. So for just we will see here, this is the hypointense line, and this is the muscularis propria. So the tumor always is mildly T2 hyperintense. So as soon as it touches this surface, this hypointense line, you're able to say that it has come to a 3-3 stage or is invading the muscularis propria. The other two stages, T1 and T2, can easily be seen on ultrasound or colonoscopy. The one pitfall comes when it's a T2 or early T3 staging is there in when we are kind of we have a mismatch. So in this, the T2, T3, early T3 shows a desmoplastic reaction also, which can be confused with either it's a T3 or a T2 stage. So the mainstay is the T2 axial images, and importance is of this muscularis propria, which is a hypointense line. Next is the important structure is the mesorectal fascia. How to identify this on MRI? This is a very thin hypointense line surrounding the mesorectal fat. Fat is bright on T2 images. This is the rectal lumen. These are the seminal vesicles. This is the bladder, which has urine and it's T2 bright. So it's a T2 images. Then we have the mesorectal fascia. It's a fascia containing the rectum. So as we go, okay. So as it's in the lower rectum, it's completely surrounded by the mesorectal fascia. Lower rectum, it's completely surrounded by the mesorectal fascia, while as we go in the upper and the mid rectum, it is anteriorly surrounded and covered by the anterior peritoneal reflection, as we're going to see here. So this is the upper section of the rectum. We are seeing the same axial images. So this is a V-shaped seagull sign of sort of a thing. This is thin hypointense structure. This is the anterior peritoneal reflection. This can be easily seen on the sagittal images as well. This is more easily appreciable on males, although it can be seen on females as well. But this it appears as a thin hypointense structure attaching to the anterior margin of the mid rectum. So this defines the anterior peritoneal reflection. So this is what I was talking about. The mesorectal fat fascia. In the high rectum, the anterior and the sort of lateral margins of the rectum are surrounded by the peritoneum, while the posterior margin is the mesorectal fascia. So, and in the mid rectum, it's only the anterior margins, the peritoneal reflection, while the other is the mesorectal fascia. And in the lower rectum, it is circumferentially surrounded by the mesorectal fascia. This is again very important as we differentiate between T3C staging and T4A. So T3 MRF positive staging and T4A. As soon as the T3, as soon as it invades, the tumor invades the peritoneal reflection, it upstages the tumor to T4A. While on the other hand, if it's going to the MRF, it's an MRF positive, it will be still T3 stage, but MRF positive. Then we have the other fascias. This is the retroprostratic fascia, the denovelar fascia, the presacral fascia, the peritoneal reflection we have talked about earlier. So this section talks about the lower rectal tumor and the lower rectal tumor anatomy. So in the lower rectal tumor, again, the important structures will be the anal canal, how to differentiate the internal sphincter, the external sphincter, and the intersphincteric space. So we'll talk about this in detail in the case when I'll show you the whole sections. But in the in the given sections, this is the internal sphincter, which is a hypointense muscle layer, and it's a and then we have the intersphincteric space, which is a fat line space. This is the fat. In the coronal oblique sections, you can see these are the fat, and then we have the external sphincter, which is divided just a continuation of the iliococcygeus, and then it comes and forms the puborectalis. So this thicker hypointense muscle is the puborectalis. So these both the axial and the coronal images are very useful for the delineating the lower rectal tumor anatomy and its involvement and its relation with the levator ani, with the internal sphincter, with the intersphincteric space, and the other, whether what is the distance between the levator ani and the tumor and the lateral pelvic walls. Even this delineation is important. Ha, sir. The fat is ischiorectal. Sir. Ischioanal would be the better word. Sir. So this is the internal sphincter. As I talked about, this would be the intersphincteric space, and the outer hypointense or the continuation of this levator ani or the iliococcygeus will be the external sphincter or the puborectalis muscle. So the external sphincter also can be seen. It's very micro kind of needs a detailed anatomical study, but it's divided into deep, superficial, and the subcutaneous part. So internal sphincter usually lies about somewhat higher than the lower limit of the internal sphincter is somewhat higher than the external sphincter. So like colonoscopically, if you see the distance from the anal verge, it will slightly differ from what we see in the MRI because of this discrepancy of the internal sphincter ending or the external sphincter ending. That would be a little slight one, 1 millimeters. So then we have the levator ani muscle. This forms the pelvic floor, just as we talked about. The puborectalis muscle forms the fibers of the external anal sphincter. The internal sphincter is the circular muscular layer of the rectal wall, and the intersphincteric space, the fat lined space appearing T2 bright, will be lying between the internal and external sphincter. So tumors below the puborectalis, that means the anal canal tumors or the lower rectal tumors, we define the CRM. What is CRM? We'll talk about this in detail. They defined as the intersphincteric plane or the levator muscles. So this is just an overview of the primary rectum template that we follow, and we tend to give all of these information in our reports. So to help the surgeons. So this is a Society of Abdominal Radiology template. So how we'll go step by step, and we'll see how to approach this rectal cancer. So step 1, we have to find the tumor. The tumor, how is the tumor looking, the signal, and the tumor with respect to the rest of the wall. So first of all, the tumor signal is usually slightly hyperintense, T2 slightly hyperintense to the muscle, and it could be intermediate. Most of the time it's gray or intermediate or slightly hyperintense to the muscles. The next point will be the elevated borders. The tumor will have some elevated borders, which differentiates it from the normal rectal wall. So this is the tumor, and it's showing some elevated borders and very high resolution T2 axial images. So, and another point important is the diffusion images. Diffusion images would help us to find clearly the location of the tumor. Second step will be the location, and it's not always that a radiologist is monitoring the scan as it happens after the time, after our usual timings. So I would request you to please clearly mention on the DRE and the colonoscopic, everything on the referral form, as it helps our technician to decide which is the tumor and to take the oblique axial and the oblique coronal planes accordingly. So in the step 2, we see the location. The location is taken from the anal verge. We try to use it as according to the long axis of the rectum. We try to measure the distance, as it will be more accurate to your colonoscopic findings. So here the tumor lies about, we'll add these images and see, lies about 7.5 centimeter. So, and the other thing will be the relationship to the anterior peritoneal reflection. So if the tumor is above the anterior peritoneal reflection or below, or it's at this level, which means it is straddling this anterior peritoneal reflection, that would upstage the tumor. Step 3 will be defining the T staging. So T staging, as we saw, the T1 and T2 tumors are confined to the rectal wall. They involve the mucosa and the submucosa, which are better appreciable on endoscopy or on endoscopic ultrasound. T3 is the beyond wall, and here is where MRI comes in role. So T3 is the beyond wall. This thin T2 high intense structure, this is the muscularis propria. And if the tumor is seen beyond this, it upstages to T3. T3 is again divided into A, B, C, and D. Less than 1 mm beyond is A, B 1 to 5, C 5 to 15, and D more than 15. But T3C, as we saw in the chart previously, it upstages to a new adjuvant chemotherapy, and it's poor prognostically related. So T3C staging is important. Then we have the T4A, or the last, which invades the peritoneum. T4B is invading the invasion of the other structures. Now, other structures includes a number of them. So pelvic organs are for sure. So it involves in males seminal vesicles, prostate, in females vagina, cervix, or for that matter even uterus, and urinary bladder, ureters. All these are the pelvic organs which upstages the tumor to T4B. Second will be the skeletal muscle involved. As soon as there is a skeletal muscle involvement, that even for elevated NI muscle, it upstages it to T4B. Skeletal muscle will include other pelvic side wall muscles such as obturator internus, such as piriformis, such as ischio-coccygeus. And the vessels are the nerves around mesorectum. So vessels, we know we see a flow void within the vessels. And if any tumor is large enough and it's invading these vascular structures, then again, it's direct invasion of the tumor, then it's again upstages it to T4B. Extra mesorectal compartment, for example, this the obturator space. The whole of this is involved in invasion of the vessels, nodes, and the nerves. This upstages it to T4B. Bone involvement, as we all know, it upstages to T4B, and even for the distant metastasis, if bone is involved, then it comes in the M category. Distant bowel, some skip metastasis or any other things sort of thing is there. Distant bowel upstages it. So this is a brief an example of the T2 tumor. So T2 tumor is just under the muscularis propria. So we see this thin T2 hypointense line. So it's beneath the muscularis propria. It's a polypoidal lesion sitting over muscularis propria, but not invading it. The T staging again involves, as we know, the T3 staging involves the MRF involvement. We have to define. So we have to define clearly which is the most aggressive part of this tumor, and that could be defined by the most distant most point of the tumor lying beyond the muscularis propria. So if the tumor is less than 1 mm from mesorectal fascia, then it's a CRM positive condition. So this happens with for the nodes, even for the deposits. So we'll be studying about the nodes in the next slides. But if even the metastatic node or a suspicious metastatic node is sitting on the MRF, is within 1 mm of the mesorectal fascia, it is a MRF positive disease. Although the prognosis for the direct tumor invasion is more than the node or the deposit sitting on the MRF. The next would be okay, I'll explain just the T3 tumor, an example of it. So this is no T2 hypointense line can be seen here. So it is definitely a T3 tumor. Now defining it further will require us to measure the distance from the muscularis propria to the outermost edge of the tumor. Now this again confuses us with the desmoplastic reaction. We'll see in the cases of usually desmoplastic reaction are linear strands, while the tumor infiltrations is the nodular, with the same intensity of the tumor, the nodular projections beyond the muscularis propria. The T4A, it's a very aggressive tumor with invading the peritoneal reflection, invading the organs. So lower rectal tumors, how to define the T staging? In the lower rectal tumors, you have to define completely the anal sphincter involvement. So this is a tumor involving the internal sphincter completely. However, the intersphincteric plane and intersphincteric space and the external sphincter is preserved. Next important prognostic factor is EMVI. It stands for extramural vascular invasion. When the tumor infiltrates the vessels and can be seen projecting beyond. I have a very nice case depicting this in my later slides. But for the theory part, this will have the same tumor intensity and it will follow the vessel course. And this is a very poor prognostic factor and should always be mentioned and should always be looked out. So it's usually a T3 tumor with extension within the lymphovascular spaces, and these are the tubular excrescences of the tumor beyond the outer wall. It's a poor prognosis related to metastasis and worse outcomes. This finishes us with the T staging. Next we will come to the N staging or the nodal stage. So nodal staging, we all know that upper rectal tumors are drained. The local regional nodes will be the mesorectal nodes, and we'll have the internal iliac nodes, and the lower rectal will go to the inguinal and the femoral nodes. So for the mesorectal, which is very important, so we have this criteria for both of this is important, size and the morphology. So on MRI, the morphology can be defined by three factors: round, whether the lymph node looks round, whether the lymph node has a heterogeneous signal, and what are the borders. How are the borders? Are they regular or irregular? As soon as two of these criteria happens in a lymph node of size like 5 to 9 mm, it comes as a suspicious metastatic. So it's not always like greater than 9 mm nodes are metastatic. Less than 5 mm nodes are also metastatic if they have these three characteristics. So these three morphology have to be clearly looked out, and even if it's a very small node, the chances of malignant morphology, the malignant changes increases quite significantly. So the criteria will be the 9 mm. If it's a 9 mm, any of these morphology will lead it to a metastatic node. If it's a 5 to 9 mm criteria, then two of these morphology will make it a metastatic, and if it's less, then all three are needed to make it a metastatic. So this is how we need only the short axis diameter. Short axis diameter is the longest diameter which the node is seen to measure. Then we have the N0, N1 and N2, just depending on the number of the mesorectal nodes. So we have to count them. I mean, it's more than 4, it upstages it to N2. This will be the extra mesorectal nodes. We have to tell them about the extra mesorectal nodes. This involves the obturator, the internal iliac nodes, and the highest involved node. So we take a T2 axial sections up to the level of aortic bifurcation also in our institute, so as to clearly define any para-aortic nodal involvement or any other retroperitoneal node involvement. Another important thing is a tumor deposit. So tumor deposits are less than 3 mm tumor deposits in the mesorectum. These also have to be defined in relation to the mesorectal fascia. If it sits on the mesorectal fascia, then it's again an MRF positive disease. So circumferential resection margin, as we know, distance of the tumor to mesorectal fascia. So in this case, the deposit is sitting on the mesorectal fascia, so it becomes a CRM positive or the MRF positive. So if it's less than 1 mm of the margin on MRI, it makes it CRM positive. This is a diagrammatically presentation just to see this, the direct tumor infiltration. You have to tell the distance from the MRF and the node as well, distance from the MRF. Staging the low rectal tumors, we have to know clearly the anatomy. These are the levator, the puborectalis, the internal sphincter, the diagrammatically representation, external sphincter, this is the intersphincteric plane, which is hyperintense, and the internal sphincter, which is again hypointense. So stage 2 is the tumor is in the internal sphincter itself. The next is the intersphincteric plane, stage 3, and in the last will involvement of the external sphincter. So this is the usual template almost followed at every institute, and if asked by the clinician, can be given in a structured format, we give in a detailed format, but all of these points are covered. So it includes the tumor location and the morphology, as you see the location from the anal verge, distance of the inferior border of the tumor to the anorectal junction. Now this distance can be given because it's very important for the surgical point of view, but usually when we characterize the lesion, it's from the anal verge we divide the tumor, low, mid or high. Relationship to anterior peritoneal reflection has to be told. Craniocaudal length of the tumor, the circumferential location. Now this will help the surgeon to get the most most invading margin of the tumor, as that's usually the centermost in a semi-annular lesion. It's usually the centermost part of the lesion. Then we have the morphology, whether it's a polypoid, ulceration, or a semi-circumferential or semi-annular. Then mucinous. This is again a very important thing can be delineated on MRI. If it's a mucinous tumor, we have the tumor signal would be T2 hyperintense, and mucinous, as we know, they are very notorious. So the T category can thus be described in respect to all these things. If it's a T4B, you have to describe this whether or not there's a maintained flat plane or there is some suspicion of involvement of these structures. The vessels, the nerves, the pelvic muscles, obturator internus, piriformis, ischiococcygis, levator ani, for pubococcygeus ilio and the puborectalis, the bones, the direct invasion of the bones, sacrum, coccyx, ali, ilium, ischium, pubis. For the lower rectal tumors, we define as internal sphincter, intersphincteric plane, or the external sphincter, and the length of the anal canal involved. EMVI is another very important prognostic factor and has to be described separately. So CRM can thus be calculated on above findings, and we have to see the shortest distance of the tumor to MRs. Then we have the nodal description. Then we have the extramedullary and the final impression as to what is the provisional T staging you can give, provisional T end staging, whether the CRM is clear, threatened, or involved, and there is suspicious node or EMVI, sphincter involvement, or the suspicious extramedullary. So we'll go with the case and to have a better understanding. केस बस वो रेडियंट स्टार्ट हो जाएगा तब, बट फिर बाद में मुझे एक बार ये भी चाहिए ओके. So this case I've got to mainly delineate the anatomy on just on a sequence. So this, as we can see, these are the oblique T2 axial images we have taken. The tumor actually is a very polypoidal tumor and sits here somewhere. We'll discuss about this later. Just to see the anatomy, we'll go from the anal verge to the sigmoid takeoff. So this is the anal verge, the lowermost limit. And then we have the sigmoid takeoff somewhere here, about S3 levels, anatomically says. And when we see the anterior peritoneal reflection. So at this level, this is a female patient again. So better delineated on sagittal section, the anterior peritoneal reflection. But here also we can see this thin hypointense structure, just abutting the anterior wall of the rectum in about mid rectal sections. Then going further down, this thin hypointense structure will be the mesorectal fascia. This is the mesorectal fat containing all the lymph node vessels. More down, we'll go and see the levator complex. And so I'll take an oblique coronal as well. So as we can see the sphincter anatomy better. हाँ सर वो तो दिख तो रही है बट दोनों में कोरिलेट कर. So this is the internal sphincter and the fat space is the intersphincteric line. These are the puborectalis muscles forming a sling, and more below the anal verge. Here similarly we can see the external the continuation of the levator ani to external sphincter and the internal sphincter muscle. This is a diffusion just to correlate our findings. So this is the polypoidal lesion here, more on the right lateral wall of the rectum, or just at the anorectal junction, I would say. So it's just reaching the muscularis propria, although the thin hypointense line cannot be seen. This again makes it, this is again a fallacy, or you would say a T2 stage or the early T3 stage. We would more reportedly as, is it a desmoplastic reaction or a T2 stage? Because there's no like complete tumor infiltration beyond this. So the next case, switch हो जाएगा. हाँ. So this was a location we see 4 centimeter from the inner verge, the anorectal junction. There was a polypoidal lesion. It was definitely below anterior peritoneal flexion. The craniocaudal length can be given of the polypoidal lesion. The circumferential location is almost the right lateral wall or the 9 to 12 o'clock position. Morphology was polypoid. It was not T2 hyperintense, so no mucinous changes. So it was a provisional T2 stage tumor. Case 2 is a 37-old male with altered bowel habits with PR bleed. So So this is not a primary staging. This is a post-treatment staging, as far as I remember. And but still, the T3 staging can be clearly talked about. And this is the tumor, and we can see the tumor projecting beyond this muscularis propria, and this appears to be the most invading portion. First of all, we'll see the the tumor we saw, and we have to tell us the location of the tumor with respect to the anal verge, and then the distance from the MRF. So this is the like most invading portion. And further above, we can see the anterior peritoneal reflection here clearly. This is the tumor is below anterior peritoneal reflection. And we also see a node sitting here just at the level of the seminal vesicle. And the node is again heterogeneous and with round morphology. And the shortest axis may be 5 to 9 mm between, somewhat like 5.5. So it makes it a suspicious node again. And involvement of the anal canal. This appears to be edematous and levator ani involvement, because the lowermost margin of the tumor is almost reaching the anorectal junction. So this appears to be involved. हाँ सर, हाँ सर, सेजाइटल में सर, हाँ सर, पोस्ट रेडियोथेरेपी चेंजेस भी हैं. ब्लैडर में फाइब्रोसिस नहीं है सर. हाँ नहीं सर, ये तो ट्यूमर एक्सटेंड. दिस पार्ट, दिस इज सेमिनल वेसिकल्स है सर. ये नहीं सर, ये ल्यूमन डिपेंड्स ऑन द कंटेंट ऑफ द सेमिनल वेसिकल्स. हाँ, ये पूरा सर प्रोस्टेट एंड सेमिनल वेसिकल्स. हाँ सर, ये प्रोस्टेट का पार्ट है, प्रोस्टेट है, और ऊपर ये सेमिनल वेसिकल्स. दिस ऑल इज नॉर्मल. नीचे सर इधर इस पे लेवल पे सर. हाँ सर, दैट्स मोर पोस्टेरोलेटरली सर. एंटीरियर सब ठीक है. इधर है involvement. So location on the anal verge was about 3.8 centimeters below anterior pectoral reflection, and it's involving the anorectal junction. Sphenocaudal length is 6.2 centimeters. Circumferential location is about 5 to 1 o'clock. Morphology is polypoid, no mucinous changes. Almost provisional staging of T3 will be given. And we saw the MRF was the tumor was significantly uh, uh, away from the MRF, so it's a CRM negative. And end staging, we see a suspicious lymph node, so it makes it a stage N1. This is a post CT again patient, but with an extensive tumor. So post CT MRI reading is definitely interpretation is riskier than because of the surrounding of fascia edematous and the surrounding structures edema. So this was the tumor sitting in the anal canal, involving the anorectal junction, extending to the lower rectal. And this, as we can see, it's a bright T2 hyperintense. So a mucinous is suspected. And this is a lower rectal tumor. We have invading or involving the external sphincter as well. More superiorly, we can see T2 hyperintense nodes showing necrosis and mucinous changes. All these nodes are very heterogeneous. Another node or sitting on the presacral region. So this makes it a higher grade. And the MRF for the lower rectal tumor, as we see, its involvement of the levator ani and the anal canal. So we have to, this upstages the tumor to almost T4 or the stage 4. So it's just, it was almost at the anal verge, just 4 mm away. It's a craniocaudal length of about 6.8 centimeter, predominantly from 8 to 1 o'clock position. It's a polypoidal lesion, mucinous, yes. It could also be a post-treatment mucinous response again, but you have to see the histopathology and correlation has to be done. But this looks more of a mucinous adenocarcinoma itself. So anal canal, we saw all the 3 structures, external, internal, sphincter, and intersphincteric space, all are involved. So this upstages it to T4B, and possible invasion of even the vagina and the pelvic floor where the ileococcygin and pivorectalis. It's below anterior peritoneal reflection. The end staging, there were number of them, suspicious lymph nodes, at least 6. So stages it to this more than 4 nodes suspicious makes it N2 stage. EMVI was negative and metastasis, as far as we saw in the MRI, was negative. Another important case, just to show the EMVI, which makes it a poor prognostic factor, and how to identify it. So the contrast images usually are not acquired, but can be acquired in a post-treatment response, just to give us more confidence. So this is a large tumor. The patient is, the patient is a post hysterectomy. So the tumor is sitting on the, we don't know the epicenter, so we are just because of the morphology and the EMVI extension and just seeing the epicenter of this tumor, it moves more of a rectal growth than a vaginal walled growth. Could be, we didn't get the follow-up of this patient still, but this appears to be a rectal wall growth. And this important thing I want to show here is the EMVI. This is the tumor extending along the vessels in a tubular fashion. Here on the sagittal images, this thing has the tumor intensity itself, and it is followed, like it's continuous as just as the vessels go in the perirectal region. So this is a very poor prognostic feature. Other things, this is of course a T4B because of the definite involvement of the vaginal wall, and more inferiorly of the posterior vaginal wall. The nodes are big, round, heterogeneous. Even other extra mesorectal nodes are sitting here with necrosis. सही पेरीरेक्टल वेसल्स के पेरीरेक्टल हाँ हाँ मतलब कोई नहीं सर कोई मेन मतलब वेन वेसल्स के so this was the case. T4B with possible involvement of vagina, pelvic muscles, even it was abutting obturator internus. This again has to be clearly seen as the lateral pelvic wall makes it unresectable. So here it's very close to the obturator internus muscle. So, and even with the posteriorly with the coccygeus muscles. So it is infiltrating left levator ani, ileococcygeal and tuber rectalis. It's involving anterior peytoneal reflection. It is EMVI positive. End staging is again at least 5. It makes it an N2 stage. And extra mesorectal compartment nodes are also there, left common iliac, internal iliac. Even the metastases are seen as the bones. Bones, we can see multiple hypo-intense round metastatic lesions. So it's a complete metastatic tube. The last, I would like to continue with my slides for the response assessment. So these are the basic we follow on the MRI for the response assessment. The T2 signal changes, how mostly if it's a darker signal, it's corresponding to a fibrosis, and the pathological response would be, it would be nice. The pathological response would be complete. It is mostly done on both T2 and ADC. The ADC values get increased, so the diffusion resolves, and T2 signal darkens on post neoadjuvant chemoradiotherapy. So this was a study conducted, and we can grade on this MR tumor regression grade. So this first is the predominance of fibrous with no other tumor signal. So we have to know the initial tumor signal as well. The 3 is the substantial tumor is there, but it's not like the dominant one. But 4 is only the tumor can be seen and little of fibrosis or minimal fibrosis, and the 5 is the unchanged. So this again new adjuvant treatment MRI report template, and it includes the YT1 staging. So down staging of the tumor if it's there, and the signal changes we have to talk about. So this was again a last case about the tumor response. So I don't have the initial images. Some technical problem occurred, but I have this area can be easily seen. Fibrotic changes can be easily seen. The anterior wall of this was the initial tumor sitting. Now you can see the posterior wall has become hyper intense and edematous. These are the post radiotherapy or the chemotherapy changes. But the tumor exactly was sitting here, and this has become darkened, and this shows the fibrosis or the post treatment response. So in the end, I would like to summarize that the location is everything, and the anatomy, of course, is everything. How to distinguish between the lower tumors, the lower rectal anal tumors are the bad ones, and to help the patient have a sphincter saving surgery, we have to define the anatomy. CRM or the MRF involvement is to be essentially given, and the MRI is to be done in the pre-operative. In the just as soon as the patient comes, no CT scan will help. MRI is the mainstay, and the structured reporting will help the clinician more. Thank you so much.
Thank you very much, Sangeeta. Very nice presentation. Yes, questions?
The tumor deposit has a definition of less than 3 mm. Huh. Sorry. Treatment. नहीं सर. अभी तो नहीं है सर.
So just one or 2 points. One is that as she in between pointed out that for the early stages, endoscopic ultrasound is better. So in the exam, when you get a case, 99% of the cases, there would be no role for endoscopic ultrasound, because most of the cases which we see in clinical practice or you will get in the exam will be uh, cases which are beyond T2 most of the times. So unless it is a polypoidal lesion which is projecting into the lumen and it has not gone beyond the muscularis propria. So role of endoscopic ultrasound, whether in esophagus or in stomach or in rectum, is for early lesions where either you want to select the case for endoscopic management like EMD or ESD or EMR, or you want to do in rectum, you want to do perennial local resection, not a complete resection. Otherwise, in most of the clinical cases, there would be very little role for endoscopic ultrasound. And the main role for MRI is to differentiate between whether you can take the patient upfront for surgery or whether patient requires neoadjuvant treatment or whether patient is unresectable. As far as adjacent organ involvement is concerned, like in many other tumors, you have to differentiate between dispensable or resectable organs versus organs which cannot be resected. So if the pelvic muscles are involved, except levator and I, so she again and again kept saying side wall muscles. Side wall muscles means coccygeus and iliacus and obturator internus. Similarly, vaginal involvement, seminal vesicle involvement, even prostate involvement may not contraindicate resection as long as you are ready and willing to resect them. So prostatic involvement alone, you can do a prostatectomy and then the urethra can be reconstructed. And if bladder is involved, then of course you have to think of pelvic exentration, but that's a separate topic in itself. The only thing is that before you think of pelvic exentration, you have to be sure that there is no extra pelvic disease and there is no extra abdominal disease. So in those cases, a PET scan definitely would be required by most groups. Okay. Sanita, Dr. Rajen Desai is one of the faculty members in our group. He wants to know when the timing of MR after neoadjuvant treatment. I don't think she would be the right person to answer that question. That I think that the oncologist will have to decide. But I suppose if you are using a short course radiotherapy regime, then probably a repeat study is not required, because short course would be given in lesions which are resectable. There, the intent of neoadjuvant treatment is to sterilize the margin. It is not to change a unresectable into a resectable or to downsize the tumor. On the other hand, if we are giving the long course or if we are following the long gap after short course, then I suppose at least 4 to 6 weeks gap, because that is the time which the radiation oncologists say the radiation takes to act. So I think it's about 4 to 6 weeks after the completion of radiation.
Thank you, sir.
Yes, Rajen. Yes, please come in.
No, thank you, I said.
Thank you.
Okay, I think we will close the session. And once again, I would like to thank Sanita for a very nice presentation. And as Dr. Vinay said, we would like to have you back in our Jaipur surgical tutorial for learning more about MRI of other diseases. Thank you. Thank you very much. Thank you, everyone.